This lecture is Fluid and Electrolytes. Given that this was a 3-hour lecture, I am going to break it up into Part 1, Part 2, and Part 3. In Part 1, the basic objectives in reviewing this are we're going to review the body's mechanisms for homeostasis, discuss how fluids can be affected in the body by various components, and review fluid excess and fluid volume deficit. When we look at fluid and electrolytes, it's the intake and output of water and electrolytes, their distribution in the body, and the regulation of renal and pulmonary functions which all contribute to homeostasis. Imbalances may result from many factors, including illnesses, altered fluid intake, prolonged vomiting, diarrhea, or drainage from wounds. Imbalances in fluid and electrolytes may be due to changes in the total quantity of either substance, resulting in a deficit or excess, in protein deficiencies, or extracellular fluid volume shifts. So clients who are older and clients who are very young are particularly vulnerable to these imbalances. So let's look at the distribution of body fluids. Fluids are held in two basic areas of the body: inside the cell, which is intracellular, and outside the cell, which is extracellular. The extracellular is made up of two components: interstitial fluid, which surrounds the cells outside of the blood vessels, and intravascular fluid, which is fluid within the blood vessels. Now remember, capillary walls and cell membranes are going to separate the intracellular and extracellular fluids. However, in order to maintain balance, fluid distribution must remain relatively constant. So let's review the total fluid comparison, the total body fluid composition. Remember, your body is made up of approximately 60% fluid. Out of that, you're going to have 20% of that is in the extracellular fluid, which 5% of that is plasma, and interstitial fluid is 15%, and intracellular fluid makes up 40% of the body weight. So this makes both of these combined together make up the total body weight. And remember, total body water varies depending on the body fat, the sex of the individual, and the age. Now, fat cells contain very little water. So even though an individual could be very large, they don't have a lot of water. Don't forget that women have more body fat than men, and infants have a high fluid volume, and older adults have less body fluid. So when we look at age and how total body fluid varies, your newborns have a huge amount of fluid compared to your individual over 60 who has less fluid. So when you're assessing turgor and whether or not you have good fluid in the body, assessing the back of the hand is not good because it doesn't take into consideration age-related skin changes. Some better ways in order to assess turgor would be to check the forehead, the chest, or the abdomen. So let's look at some things that regulate body fluids. So the regulation of body fluids is the movement of fluid through the capillaries into the tissues and is determined by two opposing forces: hydrostatic pressure and oncotic pressure. So hydrostatic pressure, if you remember, that's the water outward pressure against the confining walls, and it is influenced by the pumping action of the heart. Oncotic pressure is exerted by the plasma proteins, and of plasma proteins, albumin is responsible for 80% of oncotic pressure. Now remember, there are multiple ways of fluids moving back and forth in and out of the compartments. You have osmosis, diffusion, filtration, which remember that's a movement of fluid through a cell or blood vessel membrane because of hydrostatic pressure differences, and facilitated transport, or it's also called active transport. Facilitated transport, if you remember, is the diffusion across a cell membrane that requires the assistance of a membrane-altering system, so something like insulin that will help allow it to pass. For this lecture, we're only going to focus on two methods of regulation for body fluid compartments. Osmosis, which is the movement of water from a region of low concentration, or osmolality, to a region of high concentration, and diffusion, which is the movement of particles from a higher concentration to a lower concentration. So when the capillary pores increase in size, not only is there an increase in infiltration, but plasma volume decreases as plasma moves out of the capillary. So let's look a little bit at the hydrostatic. Remember, hydrostatic is the pushing force of the fluid against the wall of the space that it occupies. So the pressure in the blood vessel is generated by the heart's pumping action, and it varies within the vascular system. The higher blood pressure that an individual has, the more hydrostatic pressure that is going to be exerted against the wall of the capillary. So with oncotic pressure, that is the pulling force that it is exerted by colloids in the solution. Albumin is important in maintaining normal serum oncotic pressure and adequate vascular fluid volume. So if your individual is malnourished and does not have a lot of albumin, then that oncotic pressure will not hold the fluid in the blood vessels, and it will leak out into the surrounding tissue. Osmolality and osmolarity are the next things to look at. With osmolarity and osmolality, these are both terms that refer to the concentration of a solution which creates its osmotic pressure. The higher the osmolarity of a solution, the greater its pulling power. So remember, osmolarity is the number of millimoles in a liter of solution, or the volume. So fluids with an osmolarity over 300 tend to pull water. So this is a hypertonic solution because the normal body is 270 to 300, and being over 300, it's going to tend to pull water. Where if the fluid has less than 270, that's hypotonic, and so the fluid is going to leak out and make hippos out of those cells. They are going to swell. So over 300, they swell up. Over 300, they become raisins, they shrink. Under 270, they swell up. Now, serum osmolality is the concentration of particles in the plasma by weight. So with the composition, when we look at body fluids, it's composed of different things. We have solids, which are dissolved in a solution. We have solvents, which is the liquid in which the solute was dissolved. And regulation of both body fluid compartments is going to occur through osmosis and diffusion because of these two components. So osmosis, we're going to have the movement of water from a region of low concentration to a region of high concentration. And diffusion is a movement of particles from a higher concentration to a low concentration. So let's look at a couple homeostatic mechanisms that the body utilizes to try and maintain a balanced level of fluids within the body. The first and simplest mechanism that the body uses is thirst. So the triggers of thirst, you have osmoreceptors, which recognize the changes in extracellular fluid, or ECF, and then that triggers thirst. So when the ECF volume is decreased and osmolarity is increased, again, we have a thirst trigger. Cells in the thirst center in the hypothalamus, they will also shrink if they don't have enough fluid, and again, that will trigger thirst. So any kind of hyperosmolar extracellular fluid is going to trigger the thirst center. Now remember, your thirst mechanism is less sensitive in the elderly individual, making them more at risk for dehydration. They just don't have a drive because it is aging and the mechanism is not functioning quite as well. You next have the antidiuretic hormone, ADH, also known as vasopressin. This is a hormone that is stored in the posterior pituitary and released when changes in blood osmolarity occur. So what happens is the hypothalamus produces ADH. ADH is then stored in the posterior pituitary gland until it is released, and then the ADH causes the kidneys to retain water. By doing this, they're creating the tubules and collecting ducts to be more permeable and to reabsorb water. In your pituitary gland, that's where it's going to manufacture the antidiuretic hormone, and changes in plasma osmolality and blood volume may stimulate or inhibit the secretion of this ADH. So if you increase ADH secretion, that is going to cause renal retention of water. If you decrease secretion of ADH, it's going to cause an increased output of diluted urine. The kidneys play a very vital role in fluid balance. If you remember, they're excreting and reabsorbing your urine and fluids. So we eliminate approximately 1 to 2 liters of urine a day, and the body, as it's being filtered through the kidney, reabsorbs approximately 178 liters per day. If the body loses more than 1 to 2% of its fluid, the kidneys then take steps to conserve fluid by initiating one of those previous mechanisms that we talked about. As a result of this, the body is able to regulate electrolyte levels in the extracellular fluid by selective retention and secretion of the electrolyte. It can also regulate fluid volume by retention and excretion of water, and it regulates the acid-base balance. We will discuss acid-base in a couple weeks. So, in the kidney, you have your RAS system, or your renin-angiotensin-aldosterone system, and this is to help maintain a balance of sodium and water in the body. So, if you remember, this is going to occur in the juxtaglomerular apparatus, or the JGA, located in the kidney, and it's responsible for monitoring renal perfusion and solute excretion. So what we have is renin is released when there's a decrease in volume. Renin is then converted to angiotensin 1 and further metabolized to angiotensin 2, which causes increased fluids and vasoconstriction. Excuse me, hang on a second. My notes are a little messed up. So renin is released when there's a decrease in fluid volume, the increase which then leads to an increase in renin release. This renin is then converted to angiotensin 1 and then is further metabolized to angiotensin 2, which causes increased fluids and vasoconstriction if needed. Okay, so angiotensin 2 also stimulates the release of aldosterone, which causes sodium absorption in the kidney as it promotes excretion of potassium. Any drug that disrupts the aldosterone secretion or release increases the risk of excessive water loss and increases potassium reabsorption. You have the atrial natriuretic peptides, or ANP. ANP is a cardiac hormone that is stored in the cells of the atria, and it is released from the right atrium in response to atrial distension. What happens there is it decreases the amount of fluid that the body is retaining because we don't want to have that much fluid. We also have the brain natriuretic peptide, or BNP, and this is also a hormone that acts on the kidneys to help cause diuresis of sodium and water. So both of these NPs are going to do that, and we're going to result in eliminating the amount of fluid. It's a direct vasodilator, which is going to lower the systemic blood pressure, and the trigger for the release, if you remember, is an increase in the volume, which is going to increase the fluid going back to the right atrium and distend that. We have the adrenal glands, which secrete the mineral corticoid aldosterone, and it is stimulated by a fall in plasma sodium or an increase in potassium concentration. So it's primarily regulated by angiotensin 2. Angiotensin II is going to act on the distal tubules of the kidney to promote sodium reabsorption and potassium and hydrogen excretion. So the secretion of cortisol in large quantities will also cause sodium and water retention. So individuals who have disease processes that increase their cortisol are going to see a retention of sodium, a retention of fluid. The parathyroid gland is also going to secrete the parathyroid hormone, or PTH, which regulates calcium and phosphate balance. A decrease in calcium stimulates PTH, which releases calcium from the bone into the extracellular fluid. So PTH also affects calcium reabsorption from the kidney and from the intestine. So although this is not a fluid-related thing, it is an electrolyte, which is part of what we are regulating. So don't forget, calcium and phosphorus are seesaw buddies, and they have a reciprocal relationship. When one is up, the other is down, and vice versa. We have water losses that occur every day in the body. We have sensible urine loss, sensible losses. An example is urine. This is body control. We have insensible water losses that we cannot control, and those insensible losses can be anywhere from 500 to 1,000 milliliters a day. The lungs can lose about 500 milliliters a day through exhalation. The skin can have both insensible loss and sensible, depending upon the activity the individual chooses to engage in. So loss can be anywhere from an average of 500 to 600 milliliters a day up to a maximum of 2 liters per day. The GI tract also loses fluid, and it loses about 200 mils a day through feces. So let's look at some of the things that are actually in the blood to help the homeostasis. We have crystalloids, and crystalloids are solutions that contain small molecules. They're called crystalloids because they have small molecules that can flow easily from the bloodstream into cells and tissues. So if you take a look in Iggy, it has a table that talks about isotonic, hypotonic, and hypertonic. So the tonicity of these crystalloids are determined by the fluid osmolarity, so the osmotic pressure that's exerted in the pool, and it's compared to the serum osmolality, that 270 to 295. So which one of those is going to be the higher pool? And that is what's going to determine. So when we have a fluid that we're going to put into the body, we compare it to the body's normal pool, and we determine whether it's going to be the same, higher, or lower. So let's look at isotonic crystalloids first. So isotonic crystalloids are given to expand the extracellular fluid volume. So these solutions are not physiologic because if too much is given, the result is circulatory overload. So these solutions have the same osmolality as extracellular fluid, and therefore they stay in the extracellular fluid system. They have no effect on the cellular dynamics because of their osmolality is similar to the human body's. Examples of these are normal saline, or 0.9% sodium chloride, lactated ringers, and D5W. That's dextrose 5% in water. Now, what you need to remember about D5W is it may start as isotonic, however, it rapidly will convert to hypotonic. When the dextrose in the fluid is metabolized, it then becomes hypotonic. So hypotonic crystalloids have a greater concentration of free water in them. Their osmolality is lower than the ECF, and they're used to hydrate cells. However, if too much is given, water intoxication can result. So the osmolarity of these cells, these crystalloids, is lower than that of the serum plasma, so it's less than 270. And with regard to cellular dynamics, it causes the cells to swell and possibly burst. So fluid shifting is going to occur with administration as fluids shift out of the blood volume and into the interstitial space, causing the extracellular volume to deplete. So You can have a resulting cardiovascular collapse from vascular fluid depletion if you have most of your fluid leave the vascular system and go into the cells. It can also cause increased intracranial pressure as the fluid moves into the cells and swells those cells, and especially in the brain. So examples of this are half normal saline or 0.45% sodium chloride, dextrose 2.5% in water or D2.5W, and those are examples of that. Hypertonic solutions have a higher osmolality than plasma. They pull water from the cell into the circulation, so the cells are going to shrink. If too much is given, however, you can have a result of cellular dehydration as it continues to pull the fluids from the cells. So the osmolarity is higher than that of serum plasma, so it's over 300. And with regard to cellular dynamics, it causes cells to shrink and contribute to extracellular fluid volume overload. So a caution you want to watch for in these is watch for fluid overload and pulmonary edema in these patients. And be very careful administering this fluid in patients with cardiac and renal disease, as they may not be able to handle the extra fluid. Examples of a hypertonic solution are 5% dextrose in 0.9% sodium chloride, D5NS, 10% dextrose in water, D10W, or 5% normal saline. Sodium chloride. So this chart that you have here is simply a chart for those of you who are very visual, and it's easier to see it in the chart so you know which are isotonic, hypotonic, and hypertonic. Remembering the D5W is starred because after that dextrose metabolizes, it becomes hypotonic. This chart is also for those that need the visual to show what happens in the extracellular fluid and the intracellular fluid depending upon where they are. Remember, for isotonic solutions, the extracellular fluid volume will increase and there is no change in the intracellular fluid volume. In the hypotonic, the extracellular fluid volume will increase. You'll have increased water movement into the cells, and the cell size is going to increase. For the intracellular fluid volume, because water is moving in, it's going to increase. For hypertonic solution, extracellular fluid ECF, the volume is going to be increased in the blood vessels. However, the volume in the intracellular or the cells is going to decrease as the water shifts out of the cells into the blood vessels. Let's take a quick look at colloids. Colloids are solutions that contain high molecular weight proteins or starch. They do not cross the capillary semipermeable membrane, and they remain in the intravascular space for days. Colloids are a plasma expander. They're used to increase blood volume in trauma or burn victims. So this is a large molecular weight protein, and examples of that is an albumin, or your colloid could be a sugar. An example would be Dextran, or it can be a starch, such as Hespan or Hetastarch. So these substances do not readily cross the capillary semipermeable wall. They stay within the extracellular space, and they remain in the blood vessels in the intravascular space for several days. So although the colloids do not contain any clotting factors, they can affect the coagulation process. So what these colloids are going to do is they're going to increase oncotic pressure, that's the osmotic pressure of the colloid in the body fluid, with the vasculature, which is going to pull fluid from the extravascular spaces, which then increases vascular volume. Your examples of those again are albumin, Dextran, and Hetastarch. Let me see. We're going to use colloids usually when there is a severe intravascular volume loss and we're waiting for whole blood to be crossed. However, we need to maintain some caution with colloids, and that during colloid infusion, we want to monitor our patient for signs of hypervolemia. So we're going to be watching for that increased blood pressure, dyspnea, and a bounding pulse. Albumin is a major plasma protein that is available in two forms, 5% and 25%. So changes in albumin concentration affect cellular dynamics. If you increase albumin concentration, it's going to result in fluid moving back into the capillaries from the interstitial space. Decreased albumin concentration will result in fluid leaking through the capillary walls into the interstitial space. So clients suffering from underlying medical or nutritional problems can have chronically low albumin levels. And when they have those chronically low albumin levels, they already have leakage of some of that fluid out into the interstitial space. So when you look at albumin compared with crystalloid solutions, the albumin is going to remain in the vascular space longer. It's more expensive. It may cause febrile reactions, almost like a blood reaction. And it's more likely to cause circulatory overload than a crystalloid solution due to the fact that it does stay in that vascular space longer. So when would we use albumin, and what would we want to be careful of? So albumin is going to increase that vascular volume. It's used in treating hypovolemic shock from surgery or trauma, and it's given while we're waiting for whole blood. So it's given as a volume expander while waiting for that whole blood to be cross-matched. It's produced in the liver normally, the albumin is, and it's prepared from donor plasma. In this plasma, you do not have to worry about the ABO incompatibilities, and it's processed to prevent viral contamination. So what it is going to do is it's going to pull fluid from the cells to the blood vessels. Now this may cause the febrile reaction, and it may cause the circulatory overload. It's also used to support the blood pressure during that hypotensive episode. It's going to create diuresis in fluid volume excess, and it's going to help facilitate remobilization of fluid from third space fluid shifts. So we have two uses that we can use it here for. The individual who has a very low blood pressure, maybe they've lost fluid, such as in burns where the fluid shifts out into the burn area, or we have an individual who has ascites and edema everywhere that we need to pull the fluid back in so the kidneys can eliminate it, and they will do that. So remember, it comes as a 5% and 25% solution. And what that means is that that 25% solution is powerful. It will pull up to 5 times the amount of the volume of albumin that was given from the extravascular spaces. So increases can be seen in these individuals who receive albumin approximately 30 to 60 minutes after they start the infusion. One of the cautions that you want to be aware of in albumin, it is not a choice, it's a contraindication for individuals who have severe anemia or individuals with cardiac and pulmonary problems or in dehydrated patients. So you don't want to use it in anemia because the patient does not have enough red blood cells to carry oxygen around as it is, and this will further dilute the red blood cells that they do have. You don't want to use with cardiac and pulmonary patients because we're going to pull in 5 times the amount of fluid that we just infused, and their heart or kidneys may not be able, and their lungs may not be able to handle the fluid overload. And in dehydrated patients, since it's also going to be pulling from the interstitial cells, they don't have the reserves to be able to allow that fluid to come from the cells. And it should never be used to correct hypoalbuminemia or low albumin. Another colloid that we can see being used at times is Dextran. So Dextran is available in 2 strengths, 40 or 70. It's a glucose solution with colloidal activity similar to albumin in that it expands the plasma volume by pulling fluid from the interstitial to the intravascular space. However, with this component, there is no risk for any transfusion-related type illnesses. Also, you have an increased likelihood of hypersensitivity reactions during the first few minutes of administration due to the presence of a polysaccharide reacting body, so you need to be aware of allergic reactions within the first few minutes of administration. So Dextran is going to work like albumin by increasing the vascular volume, and it's used in shock that's been precipitated by hemorrhage, trauma, burns, or sepsis. The two polysaccharides, the Dextran 40 can expand the blood volume 1 to 1.5 times the volume infused, and the 70 can expand the blood volume by 80 to 120% of the volume infused. So, since it is a sugar, it can result in false elevations of blood sugar or in total protein. It can also raise liver enzymes and bleeding times. And one of the cautions that we need to be aware of is that it affects the platelets in that the platelets have decreased adhesion, which also decreases the incidence of thromboembolism, which is great, but this is not something that we're going to want to give to an individual who has altered coagulation or increased bleeding times, because we're going to just prolong those bleeding times. It can also affect the type and cross of blood due to the presence of rouleau formation, that's Rouleaux, which is a group of cells stuck together like a roll of coins. So you can have blood that would have that when you're looking at it. And that doesn't go through the cardiovascular system very well, so we need to be aware of that. The final colloid that we're going to look at is Hetastarch. It's a synthetic colloid made from cornstarch and available in a 6% solution that is diluted in 500 ml of normal saline, called Hespan. And it can also come as a 6% solution diluted in 500 or 1,000 ml of an electrolyte lactated solution called Hextend. So what happens with Hetastarch is that it's going to expand the plasma, and again is used in shock precipitated by hemorrhage, trauma, burns, and sepsis. Hetastarch will stay in the vascular system for up to 36 hours, but the plasma volume expansion will start decreasing after 24 hours. So diagnostic tests will not interfere with blood typing, but it can dilute clotting factors. The serum amylase may be increased up to 4 times normal after Hespan has been administered, so you can expect when you're looking at your labs for the next 24 to 48 hours to have an increase in serum amylase, but you should be able to see that decreasing over time as the body eliminates the Hetastarch. So excretion is both renal and liver. And it is contraindicated in severe bleeding orders. We don't want to give that. So let's look a little bit about fluid imbalances. We're almost done with part 1 after fluid imbalances. Fluid imbalances primarily affect the extracellular fluid volumes via equal sodium and water loss or sodium and water gain. Osmotic imbalances primarily affect the intracellular fluid volumes via unequal sodium and water loss or gain. So let's look at fluid volume deficit. You can have extracellular volume deficit or intracellular volume deficit. What the pathophysiology is in this one is we do not have enough water in the body. Causes of fluid volume deficit can be dehydration, hyperglycemia as the body loses fluids because of the excess blood sugar, so it gets eliminated in the urine, through GI losses and severe diarrhea, polyuria, prolonged MPO status, diaphoresis, insensible water loss through hyperventilation, and third spacing or decreased water intake, such as individuals who are stroke patients. So what happens here is the water moves out of the cells to replace a significant water loss. Cells eventually become unable to compensate for the lost fluid, and cellular dehydration begins, leading eventually, if not corrected, to circulatory collapse. Signs and symptoms of fluid volume deficit. The first one is subjective. The patient is going to be complaining of thirst. Some behavioral changes that you might see in your patient are apprehension, apathy, lethargy, confusion and restlessness, dizziness, numbness or tingling of the hands and feet, anorexia and nausea, and abdominal cramps. Objective data that you're going to see would be a sudden weight loss of 5%. In your vital signs, you're going to see a decreased blood pressure and postural changes. You'll also see flat neck veins. You might have an increased temperature. There's less fluid available for perspiration, which normally lowers the body temperature. Therefore, the body's temperature starts increasing. You might have an irregular, weak, rapid pulse, an increased rate and depth of respirations. You're going to have cool and pale skin with decreased turgor. The urine, you're going to go from oliguria to anuria. Your eyes are going to look soft and sunken. The tongue, the furrows are going to really stick out, and the oral mucosa is going to be very sticky. If you have an infant, you're going to see sunken fontanelles. So some diagnostic findings that you will find in this patient is you would expect to see, because of a low fluid content, an increased urine-specific gravity, an increased H&H, which is false because basically the fluid is concentrated, increased serum protein, again because it's been concentrated, and the same with an increased BUN. Your sodium usually is normal, and your creatinine is usually normal. So daily weights are your best indicator of fluid gain or loss, and in this individual you will see a decrease in the weight. So the nursing goal for these individuals is to restore fluid and electrolyte balance, increase the fluid intake to hydrate the patient. So you're going to have IV and blood products as ordered. You want to encourage the patient to take small frequent drinks by mouth. You're going to do daily weights and monitor the I's and O's. You're going to do hourly outputs if you actually have a patient in an acute state, so you can closely monitor it. And you're going to be watching vital signs, including postural blood pressures, to see if you have orthostatic hypotension. You want to avoid hypertonic solutions in these individuals because that may cause a fluid shift when compensatory mechanisms begin to function. So the patient's blood is already concentrated. So an example of a solution that we might give is D5W, which is hypotonic and low sodium, to help treat dehydration. Once the dextrose 5 is metabolized, the water will then move into the cells to rehydrate. However, if you give the hypotonic solution too quickly, it's going to move from the veins to the cells, and that can lead to cerebral edema. If cerebral edema is bad enough, it can lead to seizures, coma, and death. So you're going to give this gradually over 48 hours. An example would be giving them normal saline or lactated ringers for hypovolemia. And you're going to be doing frequent skin care. The lack of hydration is going to cause dry skin, which is going to increase the risk for breakdown. We're going to give medications as ordered. We need to stop if they have vomiting. We need to give them antiemetics. If they have diarrhea, antidiarrheals. We're going to do frequent mouth care on these individuals. Their mucous membranes are dry, so they are at risk for breaks in their mucous membranes. And we're going to we're going to monitor their BUN and hematocrit levels, and we should be starting to see those return closer to normal. And again, we're going to monitor that fluid replacement so that we don't go from being underhydrated to overhydrated. So let's look at fluid volume excess. The pathophysiology of this one is that we have too much fluid in the body. So fluid volume excess, or isotonic fluid volume excess, is going to result from an equal gain in sodium and water in the extracellular fluid. The osmolality is not significantly affected because of the equal gain in solute and water. If this becomes an excessive gain in ECF volume, the fluid will shift into the interstitial space, and that will result in edema. So what we have is, for causes of fluid volume excess, could be overinfusion of hypertonic solutions. Also, we can be using those plasma proteins and colloids such as albumin. The individual can have an excessive ingestion of sodium, excessive saline enemas, corticosteroid administration, CHF, chronic renal failure with decreased or inadequate urine output, chronic liver disease, low albumin as seen with renal disease or malnutrition, Cushing syndrome, and cirrhosis of the liver. So we have that hypoosmolar water excess in the extracellular compartment is going to lead to intracellular water excess because the concentration of the solutes in the intracellular fluid is greater than that in the extracellular fluid. So water is going to move to equalize the concentration. It will move into the cells and it will cause swelling of the cells. This is the most common, the most common cause of this is an increase in sodium. So signs and symptoms that we're going to have for excess fluid volume. There's no single diagnostic test to confirm hypervolemia. So subjectively, your patient is going to have shortness of breath as they start to have fluid filling up into the lungs, and the patient will become confused. Objectively, they're going to have a sudden weight gain of 5 pounds. They're going to have vital sign changes such as an elevated blood pressure, full bounding pulse, tachypnea. They're going to have an elevated central venous pressure. With the urine, they might have polyuria or nocturia. And when they sit up, those neck veins are going to be engorged. You're going to hear crackles in the lung fields. You're going to have dyspnea. Sometimes you're going to have a frothy cough, and that's because the fluid is backing up into the lungs. Edema is you're going to see that first only in dependent areas, but then as the fluid volume excess continues, it's going to become more generalized. Some diagnostic findings that we'll find is that the sodium is normal, and we're going to have a decreased hematocrit and BUN because the blood has been diluted. And we're also going to have a decreased protein, again because it's been diluted. And if you took a chest x-ray of this individual, you would see fluid in their lungs. So the nursing goal for these individuals is to maintain oxygen to all cells and promote excretion of excess fluid. We're going to do this again by maintaining I's and O's, doing their daily weights. Don't forget, 1 kilogram of weight is equal to 1,000 milliliters of fluid. We're going to monitor for the elevated blood pressure or respiratory rate, and we're going to monitor this usually at least a minimum of 4 hours. We want to listen to those lungs for crackles and assess for complaints of dyspnea. These individuals are going to find the position of semi-Fowlers or Fowlers more comfortable to help aid in their gas exchange. Oxygen and bed rest are usually used to support the patient and prevent additional strain on the heart. We're going to monitor the hematocrit and BUN that they are returning closer to normal. We're going to assess for peripheral and sacral edema. We're going to turn that patient every 2 hours if they're edematous, because edematous skin is more likely to break down. We want to measure all edematous parts to make sure that they are resolving. A very tight control over IV fluid and oral fluid administration needs to be maintained. And we need to monitor the therapeutic and adverse effects of medication. You can expect your patient to be prescribed Lasix or Diaril or spironolactone for diuretics. And we're going to monitor electrolytes, especially magnesium and potassium, and teach the patient about a low sodium diet to help eliminate fluid. So we did the I&O question in class, so I am not going to go over this again. However, I will give you the answer again in case you didn't get it wrong. The total intake, if you add it all up, should have added up to 2,460. The output should have been 1,100. So this individual in the first INO question would have had a 1,360 ml fluid excess. In the second INO question, your total output should have been 300 mils. Your input should have been 100 mils, which gives you a deficit of 200 mils for your answer. So this is the end of part 1 of fluid and electrolytes, and then I will continue on and record part 2 and part 3. Thank you. If I can remember how to stop this, I will for you.